We are live.
Dr. Aruna, please start.
Yes, ma'am. Good afternoon, ma'am, and other judges. Myself, Aruna Singh, and I'm from Raigarh Government Medical College. My college is in process of opening eye bank. Therefore, I'm giving a presentation on endothelial layer of cornea. First, I would like to start with the layers of cornea. There are 6 layers of cornea: anterior to posterior, epithelium, Bowman's membrane, stroma, that is also called as substantia propria, Dua's layer, also called as predesmate membrane, Descemet's membrane, and endothelium. I'm giving my topic is corneal endothelium. First, it is the innermost and posterior layer of the cornea. It is single layer and flat polygonal cells. It is mosaic in appearance. There is no in vivo proliferation. Therefore, damage of endothelium would lead to opacity. It is derived from neural crest cells and fibrous layers of mesenchyme lying anterior to the optic curve. In slit lamp, we can examine by specular microscope. The cell count normally is 2,800 cells per mm square. In any case of there is cell morphology, pleomorphism, and polymegathism. As we can see from the picture, a healthy endothelium looks like in the first case, first picture, it is polygonal in shape, and in the second picture, we can see the change in the morphology of the cells of the endothelium. And in the third one, there is polymegathism. Now the functions of endothelium, it is metabolically active layer of the cornea, and it has barrier function. Tight junctions are present in this. Therefore, it prevents the water from going into the cornea and prevent corneal edema. And also there is active pump, which plays main role in the maintenance of corneal transparency. Recent advances, it is related to the keratoplasty, as we can see here. It is Descemet membrane endothelial keratoplasty, and also artificial endothelial layers have been created for keratoplasty and eye donation. In the summary, I would say that it is the posterior-most layer of the cornea, consisting of single layer of flat polygonal cells, which on slit lamp biomicroscopy appear as mosaic. And my takeaway message is, by donation of eye by one person, we can give vision to 2 people. And it is same as donating your girl, and it is very necessary. Thank you, ma'am.
Thank you, Dr. Aruna. This is an undergraduate presentation.
Yes, ma'am.
And the topic is just cornea.
Yes, ma'am.
Okay, Dr. Nader.
Yeah, it was, I think, meant to be 6 minutes.
Yes, it was less than that, so it's okay.
Yeah. Next speaker, we can call the next speaker.
Yeah. Thank you.
Thank you so much.
Good afternoon, ma'am.
Good afternoon, Mr. Sorry, what is your name?
I'm Samar Thakur from Dr. RPGMC Tanda.
Okay, Dr. Samar. Pehle Dr. Aruna ne kiya. Dr. Samar, please start.
Yes, ma'am. Ma'am, is screen visible?
Nothing is visible right now.
Wait. Is it visible right now?
Visible.
Yeah, it is visible.
Yes, ma'am. Good afternoon, respected judges. My name is Samar Thakur. I am from Dr. RPGMC Tanda, and I will be presenting a clinical case of COVID-19 conjunctivitis. So, a 21-year-old boy.
Dr. Huma and Dr. Sanjeev.
So, 21.
This session is going on.
Ma'am, may I start?
Yes.
A 21-year-old boy
Yes,
presented
Dr. Thakur, start.
Yes, to OPD with chief complaints of redness of eyes, foreign body sensation, ocular discomfort, joint pain, and fatigability. On ocular examination, he had bilateral conjunctival hyperemia, mild follicular reaction, which was more in the left eye than the right eye. He was diagnosed as a case of follicular conjunctivitis and was treated conservatively with CMC eye drops and cold compresses. On further evaluation, he was diagnosed with COVID-19 on RT-PCR done on a nasopharyngeal
I'm so
swab.
sorry, Dr. Samar, just 1 second. Please, can the organizers check there's too much of background noise and echo? Can we please have, sir, good afternoon, sir.
Good afternoon. Good afternoon. Good afternoon.
sir.
Carry on. Carry
Good
on.
afternoon,
Okay,
sir.
thank you.
And
Dr.
find out
Samar,
the
please
best
carry
one from
on.
this
Dr. Samar
session.
is listening. Please take note.
Yes. Find out the best one. Best one from this session.
Okay,
Best
sir.
one from this session. And how many participants are there in your session? May I
Two,
just
sir.
have a look? Aruna Singh is there. I can see.
Dr. Aruna is just presented. Now, Mr.
Aruna is
Dr.
there.
Samar is
Dr.
Then
Thakur.
Ma'am,
Dr.
just,
Thakur is there.
Samar Thakur is there.
Yes,
Yes,
sir.
sir. Second presentation.
And Mriganki Nandi. Mrigakki Nandi.
No, sir. No
Nobody
one
else
else.
is there.
Mrigakki Nandi is not there. Okay. Vinayak Venkat Subramaniam is there.
Yes,
No, sir.
Yes, Vinayak
Yes, sir.
Subramaniam is there. All right. And Utkarsh Dubey is there. Mr. Utkarsh Dubey from Kolkata is here.
Ma'am, but your name is written in hall 6, Yoga Panda, hall 6. Yes,
Okay.
okay.
इधर में आउट पे है
यहाँ पे दो है, रुमा दास and संजीव मित्तल.
ऑलरेडी हियर
नहीं, वो मैं they have not yet done.
अच्छा ठीक है उनको चालू करो
Dr. Samar, you can start again your presentation.
Yes, ma'am. My presentation is on clinical case of COVID-19 conjunctivitis. A 21-year-old boy presented to OPD with chief complaints of redness of eyes, foreign body sensation, ocular discomfort, joint pain, and fatigability. On ocular examination, he had bilateral conjunctival hyperemia, mild follicular reaction, and serious discharge, which was more in the left eye than the right eye. He was diagnosed as a case of follicular conjunctivitis and was treated conservatively with carboxymethylcellulose eye drops and cold compresses. On further evaluation, he was diagnosed with COVID-19 on RT-PCR done on a nasopharyngeal swab sample. After diagnosis of COVID-19, he was managed at home, after which he made full recovery without any complications. Now, a brief introduction to the COVID-19 conjunctivitis. COVID-19 can present with conjunctivitis, which usually occurs early in the disease. Among the previous coronaviruses, there were no ocular disease reported, and the COVID-19 conjunctivitis can occur as the first and the sole symptom without any systemic involvement. Although COVID-19 conjunctivitis itself is not a very frequent symptom of COVID-19 disease entity, but it is the most common ocular symptom or ocular manifestation of the COVID-19 disease. Now, the etiopathogenesis. The risk factor for COVID-19 conjunctivitis is direct contact with the person having COVID. Transmission occurs through droplet inoculation and from the nasopharynx through reflux via nasolacrimal duct. There is another proposed route of transmission, which is through the lacrimal gland, through the lacrimal ducts into the eye. But since the only ocular manifestation of in the eye is conjunctivitis and there is no lacrimal gland involvement reported, it is not a established route of transmission. After the transmission, for the entry into the cell, the virus uses ACE2 receptor on the conjunctiva, limbus, and cornea. Conjunctival specimens also express TMP-RSS2, which also helps in the entry of the virus into the cell. Now, although the ACE2 receptor are present on conjunctiva, limbus, and cornea, their density is very less, and the only ocular manifestation is conjunctivitis. There was only one reported case of keratoconjunctivitis in which the cornea was involved by Chima et al. The reason for not involving the cornea or the limbus is that the tear film usually washes away the dead cells and the virus-laden cells into the conjunctiva, into the inferior palpebral region. That's why the only reported disease was conjunctivitis and not the keratoconjunctivitis or the keratitis. Now, after the entry of the virus into the cell, there is viral replication followed by immune hyperactivity and then tissue destruction. After tissue destruction, cell death results the release of virus into the tears. Now, the virus-laden tears can go into nasopharynx, therefore can result in involvement of the lungs in a patient who didn't have systemic COVID-19 and was presented initially only with the COVID-19 conjunctivitis. Now, there had been case reports in which there was sustained replication in conjunctiva even after the recovery from the COVID-19 disease, suggested by a case report of a patient with persistent positivity of the conjunctival swab despite nasopharyngeal tests remaining negative. Interestingly, there were also the reports in which the COVID virus RNA was isolated on the normal conjunctiva of COVID-19 patients without ocular manifestations, which implies there is a viral spreading via conjunctival contact even in the patients without conjunctivitis. Now the symptoms and signs. So the COVID-19 conjunctivitis presents itself as any normal viral conjunctivitis. The symptoms are the patient could be asymptomatic. He can have watering, foreign body sensation, red eye, mild photophobia, or ocular discomfort. The signs pertaining to COVID-19 conjunctivitis, it usually begins as unilateral hyperemia of eye with follicular reaction, which occurs in the inferior palpebral because all the tears have tendency to collect in the inferior palpebral region. Then the patient usually presents mostly in the clinic with a bilateral conjunctival hyperemia, which can be associated with phimosis, follicular reaction of the tarsal conjunctiva, epiphora, watery discharge, mild eyelid edema, and it can also be associated with enlargement of the preauricular and submaxillary lymph nodes. Here you can see the patient. He has follicular conjunctival reaction in the upper and the lower fornices, serous secretion, and the mild phimosis. You can see it in the picture. Now, diagnosis and management. For the diagnosis of COVID-19 conjunctivitis, the sample we collect is the tear sample, which can be collected by Schirmer strips or by the conjunctival swabs. We usually collect the sample by conjunctival swabs. Although RT-PCR is a gold standard, specific and sensitive test for COVID-19 disease, but it is a specific but very less sensitive test in the diagnosis of COVID-19 conjunctivitis. The lesser sensitivity pertains to the fact that the concentration of the ACE2 receptors and concentration of the virus in the tear sample is very less as compared to the lungs or other samples taken from elsewhere. Now, it is recommended that there should be 2 consecutive negative RT-PCR test results before we can consider a patient safe, the patient who is having COVID-19 conjunctivitis. For the management of COVID-19 conjunctivitis, like any other viral disease, it is self-limiting, but we can prescribe patients lubricants such as carboxymethyl cellulose eye drops, and we can also tell him to have cold compresses. We can also give prophylactic topical antibiotics for secondary bacterial infection. In some cases, in some case reports, it was suggested that the use of ganciclovir and acyclovir was followed by the improvement of the symptoms in COVID-19 conjunctivitis, but it isn't in general required. Now the prognosis. COVID-19 conjunctivitis resolves by itself without any morbidity if systemic complications do not occur. But a meta-analysis concluded that the conjunctivitis in COVID-19 patients is usually associated with a more severe form of disease, both clinically and biochemically. The patient had a worse profile, and overall it had a worse outcome. So thank you. The only thing we have to remember in this whole COVID-19 conjunctivitis case scenario is that a patient can have COVID-19 conjunctivitis without systemic involvement. A patient can have positive conjunctival swab without any ocular or systemic involvement. So he can be a carrier which can spread the disease to another person because he is asymptomatic. Now also the patient can have persistent positivity even if his nasopharyngeal swab is negative, and also the patient can have a isolated COVID-19 conjunctivitis without systemic involvement. Thank you.
Thank you so much, Dr. Nada.
Yes, it was a very nice presentation and very well completed
Thank you,
in
ma'am.
Yes.
And I think
Thank you,
one
ma'am.
question, if it is a cornea involvement, we are going to use
Yes, ma'am.
acyclovir or anything else also?
Ma'am, there was only one case reported and that was treated with acyclovir and ganciclovir.
Where is it reported?
Topical eye drops. Ma'am, it was given by Chima et al. Yeah, ma'am, I had taken the reference from an online case report provided by Chima et al.
Right. Very well done.
Okay, thank you, ma'am.
Dr. Manisha.
Very nice presentation, and it covered the whole gamut of presentations, and it was a relatively new thing. Plus the basics you have given in that, so good. So we can go on to the next speaker, Dr. Nada. Okay?
Yeah, Dr. Vinayak, I think he is waiting for his
Okay. So Dr.
Vinayak.
Yeah, good evening, ma'am. I'm Vinayak.
Start your presentation.
Yeah, yes, ma'am. Just a Ma'am, just 1 minute, ma'am. I'll just get it set up.
Yes, sure, Dr. Vinayak. Is there a next speaker also ready after this? Mr. Sunil? Anybody else? Mr. Sunil for Hall C?
Ma'am, is my screen visible?
Yes.
Yes.
Yeah, okay, ma'am. So I'll get it started. So my topic today, I'm Vinayak from Government Domandura Medical College in Chennai. So my topic for today is a National Program for the Control of Blindness and Visual Impairment. So in this presentation, we'll be covering the contents. The contents include introduction, what were the objectives and achievements of this program, what are the strategies, and what can be the new improvements we can add to this program. So the National Program for Control of Blindness and Visual Impairment was launched in 1976. It was a 100% centrally sponsored scheme. So the main aim was this program was to reduce preventable blindness from 1.4% to 0.3%. And as of 2015-16, the program has actually achieved its target. The current preventable blindness levels are 0.36%. So what were the main objectives of this program? So the main objectives were first to continue cataract operations. So to perform around 66 lakh cataract operations, school eye screening programs, and distribution of free spectacles, and also to reduce the backlog of preventable blindness by treatment and identification. And also there was a strategy called Eye Health for All. So by which the government gave universal eye care services to everyone. So this program also focused on strengthening that strategy. And the other objectives include community participation on eye diseases and participation of voluntary organizations and to strengthen the basic infrastructure. So coming to the strategies adopted, the first was when this program was launched in 1976, cataract was found to be one of the major diseases which caused preventable blindness in Indian population. So the initial program strategies included or focused mainly on cataract. So the first one was free cataract surgery in government hospitals and also screening eye camps for elderly population. So by this way, they could actually screen a lot of elderly population, identify cataract in their early stage, and provide curative treatment. And at the same time, children were also a very high risk group. So screening camps were also conducted for children. This was mainly to find out any early onset refractive errors. And then at that time, the rural-urban divide of the program, the rural-urban divide for healthcare was also very huge. So through this program, the underserved areas were also covered through public and private partnership. And the general considerations or strategies include capacity building of the health personnel and information, education, and community activities for awareness on eye care. Apart from that, the local regional institute of ophthalmology, the medical college hospitals, they were all strengthened with not only infrastructure, but also with proper trained individuals. And the emphasis was also on eye care program for conditions apart from cataract and refractive errors. So these conditions were diabetic retinopathy, glaucoma, and at that time, trachoma was also very prevalent. So trachoma was also included in this program. And also multi-purpose mobile units for covering underserved areas. So they were also set up. A very important aspect of this National Program for Control of Blindness was the Vision 2020 Right to Sight. So this Vision 2020 was not an Indian initiative. It was a global initiative which was launched by the WHO, but later on it was also adapted within this program. So the target diseases in Vision 2020 were cataract, glaucoma, refractive errors, diabetic retinopathy, childhood blindness, and corneal blindness. So the main point of Vision 2020 was human resource development, infrastructure development, and technology development. So, I would like to draw your attention to this chart here. So this was basically how the infrastructure was in Vision 2020. So I can see at the primary level, we had 20,000 vision centers. So what do? Basically, they test the refraction, they prescribe glasses, and they teach primary eye care and school eye screening programs and all those things. Then at the secondary level, we have 2,000 service centers for cataract surgeries and other common eye surgeries were performed. Then we have 200 training centers for the eye healthcare individuals, and 20 centers of excellence where basically strategy development was done. Now, all these have been successfully adopted in the program and successfully implemented. So that's the reason why in 2015-16, the program achieved its goal of bringing down blindness to 0.3% of the national average. Now, what are the other improvements which I believe can be done here? The first point is about nutrition. This program anywhere does not speak about nutrition. So, of course, the current guidelines include regular vitamin A prophylaxis, especially for those children who face the danger of deficiency. But again, there is no guidelines for adults or anything. I believe that strict nutrition controls, nutritional guidelines can help adults go a long way, not only in preventing cataract, but also diabetic retinopathy and all those things. And then we come to school measures. So screening of the children in school is a wonderful job, but it does not serve the purpose. What I believe is that treatment is good, but if we could prevent the disease, it would be much better. So what I say, what are the measures which I give is general school measures. So good illumination, proper distribution of students in the room, good visualization of board from each corner of the room, and in order to reduce eye strain. So these are the measures which I suggest. Next is eye hygiene. So eye hygiene. So education for the general population about eye hygiene is very, very important. Many people do not know what is eye hygiene. For example, many people use a lot of irritating substances like kajal, surma, and all those things. So these are irritating substances. These can cause damage to your eyes. So they do not know about this. So we need to educate the population. And also protection of eyes from dusts by goggles and from UV rays by appropriate sunglasses. And then quacks. Quacks are a problem for any medical field. So this program needs strict rules about quacks, because currently we all know that quacks perform a lot of cataract surgeries that end in a huge disaster. So proper legal and legislative rules are needed regarding quacks. And the final point of presentation is ocular trauma. Ocular trauma recently is picking up pace, and it's basically a cause of preventable blindness. So how can you prevent ocular trauma? Very simple logic is protection. So very simple, protection of protective eyewear, especially in high-risk groups, and of course, proper training of individuals, especially those who are handling chemicals or machineries or who are prone to such traumas, and goggles, which we are giving to the individuals who are working in high-risk jobs, should be hard and sturdy enough to handle the chemical and mechanical blows, and drivers should wear proper head protection gear and do not handle anything without knowledge on how to do it. So these are the certain improvements which I suggest to the current program. And with that, I would like to end my presentation. Thank you so much.
Thank you, Dr. Vinayak. I have one question to ask. You feel that school screening is not important?
No,
You're saying eye hygiene can be an improvement. Eye hygiene. Sorry, let me complete.
Yes.
You have recommended eye hygiene instead of school screening. Eye hygiene will not prevent refractive errors or other conditions which can lead to amblyopia or potentially decrease or obliterate the vision in any eye. Okay. So keep that in mind. School health programs are essential to our screening for refractive errors and improving eye health in all individuals, because it starts at a young age, and we are carrying out projects based on this, and it's being encouraged by the government. So do not ever say, see, you may praise something, but don't ever say that eye screening for refractive errors or eye health in the primary school level is not important. That I would strongly disagree with. And the measure you suggested, eye hygiene, which is a good thing, but it will not prevent the problems that you're screening for. Okay.
Okay. Thank you for the views.
Good presentation. Dr. Nada, comments?
Yeah, it was a nice presentation. There was little time. I think he has exceeded that time limit.
Yes, he exceeded the time. Yes.
Yeah. But because the timer is not there, so we can't really put it on record that.
Yeah.
We are judges, na, Dr. Manish?
Yeah. No. We are all pro doctors.
Yes.
So are there any other speakers now? Any other speakers? Mr. Sunil, who is coordinating for Hall 3?
Ma'am,
think-
there is no other speaker as of now. I think Dr. Samar and Dr. Aruna was only.
So
there.
we had Dr. Aruna, Dr. Samar, Dr. Vinayak, huh?
Yes, only 3 are here, ma'am.
And we have to give 3 prizes.
That I'm not aware of, ma'am.
So good. So everybody is a winner. We'll give in our results. Thank you so
Yeah,
much.
yeah. Thank you so much. Thank
Thank
you.
you, ma'am.
So
Then
you want me
we'll
to?
leave this
Thank
all.
you.
So
because I
you can I close this session?
Yeah.
Yeah, I think it's closed. We don't have anything else.
Yes.
Right? This call now.
Sir, I
Yes.
have a query. Sir, will there be any other session for UG students?
There's nobody there, so how?
Hello?
Just to tell, yeah. Dr. Manisha, we have to leave, I think, yeah, from here.
I think
Okay.
we'll leave.
So
Okay, thank you.
I'll close this session, ma'am.